All right, everyone. The keynote's ended, so hopefully people will start coming in now. So I'll get us started with some of the introductions, and then by the time everyone's joined us, we'll be ready to go for the talks. So welcome to this ASB Symposium on the evolving role of biomechanics for improving the health and performance of cancer patients. My name is David Lips. I'm an assistant professor in the School of Kinesiology at the University of Michigan, and we'll be joined today with the symposium from a variety of speakers from many other institutions, including the American Cancer Society, Ohio State University, the University of Waterloo, and Emory University. It has been a long battle to get this on the agenda. We had planned to do it last year in Atlanta because the American Cancer Society is headquartered about 2 blocks from the meeting site. We hope to do it again this year from Atlanta, and we're just going to make the best we can this year. And I'm really excited to bring this group of presenters in the symposium to ASB. So there are approximately right now 17 million cancer survivors living in the United States. Cancer is associated with chronic disease and morbidity, whether or not you're looking at the development of an increased risk of cardiovascular risk after having a cancer diagnosis to the effects of the treatments used for cancer, many of which are either systemic and could increase your risk of things like peripheral neuropathy and falls, or they may have localized issues where maybe it increases your risk of having increased joint pain, restricted mobility, etc. On the other end, we know that physical activity is really important for reducing both cancer prevalence and treatment morbidity. So getting people to exercise, getting them the proper therapeutic care they need after cancer treatment, and developing ways to monitor patients in a way that we can understand when these deficits are beginning and how to intervene for these patients is really important. And that's where I think ASB as a community fits in. I think that the biomechanics community can play a very crucial role in reducing the overall burden of a cancer diagnosis on the overall quality of life of cancer patients. You might see a little bit of focus on breast cancer. I want to just from the beginning let known that when we talk about cancer, we're talking about all sorts of cancers are having functional morbidities that could potentially be lessened by physical activity, as well as intervening from the biomechanics community. So my primary objectives for today is to highlight the benefits of physical activity across the continuum of cancer care. And for that, we have some great speakers from the American Cancer Society. They'll talk about a lot of the great previous and ongoing surveillance studies that have been done in this realm. We're going to exhibit how biomechanical insights and technologies can improve the health and well-being of cancer patients. So we have a lot of great talks today. All over the scope of biomechanics, looking at gait, balance, muscle mechanics, shoulder health, and looking at how biomechanical insights and tools have been used to improve the health and well-being of patients. And finally, I'm hoping to motivate students and postdocs who are still navigating what they want to do with their career to see if they can find a great question at the intersection of oncology and biomechanics. So hopefully 10 years from now at an ASB meeting, we can actually have a whole podium session or poster session devoted to cancer and biomechanics so we can keep moving the field forward and improving the quality of life of cancer patients in the US. So we've assembled a great panel for today. It's going to be bookended by 2 speakers from the American Cancer Society. We have Alpa Patel, who's the Senior VP for Population Sciences of the American Cancer Society, who will talk about physical activity across the continuum of cancer care. And Erica Ruiz-Pinilla, who is a principal scientist and population sciences at the American Cancer Society, who will be talking about some of her digital interventions for promoting physical activity in breast and cancer survivors. In between, Ajit Chaudhari will be talking about his work looking at gait and balance in chemotherapy. I'll talk about some of my work on muscle mechanics and the effects of radiation therapy. Jacqueline Michakevich will be talking about her work looking at shoulder mobility and muscle activity in breast cancer survivors. And Joe Nocera from Emory will be talking about his work designing a resistance training intervention for breast cancer survivors. So I know that many of you might be trying to jump between sessions. I hope you'll stay for the full session. I think you're going to learn a great deal. But I did post the presentation times up here since they're not posted in the online on the Crowd Campus app. So if you're looking for a specific presentation or presentations, these are the times that they will be occurring at. So with that, I am going to turn it over. Excuse me, one more thing. Audience participation, please participate, please ask questions. We'll have time for 1 or 2 questions between each presentation. So please ask that in the Zoom chat, and myself or one of the other individuals participating on the panel will direct those questions towards the speakers. At the end, we have time for a 15-minute or so panel discussion. I'm gonna help moderate those questions again, ask those in the Zoom chat, and I hope that you'll join us afterwards in the Spatial Chat S1 Borelli room to further discuss today's panel and all the topics discussed today. So with that, I'm going to unshare my screen, and I am going to welcome Alpa Patel, who again mentioned is Senior VP for Population Sciences at the American Cancer Society, and she'll be talking today about the importance of physical activity across the continuum of cancer care.
Thank you, David. And can I just confirm that you can see my screen? Perfect. So thank you all so much for having me here today. I'm really excited to be able to give you a whirlwind snapshot of really just the benefits of physical activity across the cancer continuum. Spent the better part of the last 20 years doing epidemiologic studies on physical activity and cancer. So when we think about the burden of cancer, as David mentioned, we have just this year alone about 1.9 million new cancer cases and over 600,000 cancer deaths expected. So from an absolute number of lives, there's clearly a tremendous burden of cancer, but from a cost perspective as well. It's estimated that there's about $160 billion in cancer-related healthcare costs annually. So this really makes a compelling case for improved ways to prevent and treat different types of cancer. This is just a broad snapshot of modifiable risk factors for cancer. And you can see that if we were able to intervene on all modifiable risk factors, we could prevent about 42% of cancers. But specifically related to physical activity, there is about 3% of cancers, which translates to over 46,000 lives that wouldn't hear those words, "you have cancer." This study, when it was done, was based on breast, endometrial, and colon cancers, which up until recently were the 3 cancer types for which there was sufficient evidence for causation related to physical inactivity. But as I'm going to show you over the next few slides, the landscape of the impact of physical inactivity on cancer has really grown. From a biologic perspective, we know that, of course, there's direct weight-related impact. And on that previous slide, in case you missed it, about 8% of cancers are attributed to excess body fatness. So the mediating effects of physical activity on body weight is an important mechanism. But there are a lot of independent pathways as well in terms of different types of hormones and metabolic pathways that would lead to lower risk of developing or dying from cancer. In epidemiologic studies, we most often look at leisure time physical activity, or what we consider intentional exercise activity. So that moderate to vigorous physical activity, you'll see throughout some subsequent slides it being referred to as MVPA, calculated as metabolic equivalents of energy per hour per week. And so these are broken down into moderate intensity, things like walking, where, of course, I think that everyone here knows about energy expenditure, so I don't need to define that, but moderate intensity activities like walking, or more vigorous intensity activities like hiking or jogging. So when we think about leisure time physical activity in this way, the current public health recommendations for how much activity you should get for overall health is about 150 minutes to 300 minutes per week of moderate intensity activity. So if you're thinking about something like walking, If you're thinking about more vigorous activity, it's half that. It's 75 to 150 minutes per week. And when you look at large population studies, you can see here that, of course, the greatest benefit goes from doing nothing to something, but you really start to see that dramatic decline continue in that optimal range, but then it starts to level out a bit. So that's really what has driven where those public health recommendations are. There's been less known, and in fact, the first major studies at the population level on physical activity and cancer only date back to the 90s. So the National Cancer Institute has actually put together a really nice collaboration called the NCI Cohort Consortium. And within that, there's a physical activity collaborative group. And here we've pooled 12 cohort studies. These are longitudinal epidemiologic studies that generally have tens to hundreds of thousands of participants that are all recruited before cancer diagnosis and then followed for decades. These 12 studies total have about 1.5 million participants. About just over half are women, and the age range for most is 50 to 65 years old. And in that, during follow-up, we actually observed almost 190,000 cancers. And so using this really powerful collaboration, we were actually able to look at beyond breast, endometrial, and colon cancers, which are the three highlighted here in blue. Are there other cancers for which, if we look at simply the highest level of activity, the top 10%, in any study versus the lowest level of activity, that bottom 10%, where do we see signals that at the population level, physical inactivity may be detrimental to cancer risk? And in fact, an additional 10 different sites popped up, including many other common types of cancer. So we then, using the same population, took those 13 sites and did a much deeper dive. And I don't by any means expect you to be able to see these numbers, but really what I want to point out is across these panels, you can see that blue shading, and that is what the recommended levels are. So you can see those dose response relationships for each individual cancer type. You really get to optimal benefits for most cancer types by meeting physical activity recommendations that are currently published. So collectively then in 2018, the Physical Activity Guidelines Advisory Committee, which is the federal committee that puts out physical activity guidelines, added a number of different cancers from their last iteration of the guidelines back in 2008 to say that there is sufficient, moderate, or limited evidence for causation in humans for a number of different cancer types related to physical inactivity. So it really starts to draw even more attention of the value of promoting physical activity, which you'll hear about later in individuals for both cancer prevention. And now I'll briefly just show you that for survival as well. So led by the American College of Sports Medicine, we had an international roundtable just a handful of years ago where we looked at the consensus literature on post and pre-diagnosis physical activity levels among different types of cancer survivors and how it relates to overall or cause-specific mortality. And so at the time, there was sufficient evidence, and unfortunately only remains sufficient for breast and colorectal cancer survivors. You can see here that there's about 17 studies in breast and almost 10 in colorectal cancer survivors, where both for colorectal and breast specific mortality, as well as all-cause mortality, a clear benefit with being more physically active and lower risk of death. So the relative risk about 18% lower for breast cancer specific mortality if you're physically active, and about a 23% lower mortality for colorectal cancer survivors. And in the post-diagnosis space, encouraging physical activity after a cancer diagnosis is associated with an equal or even stronger benefit for both cause-specific mortality and all-cause mortality. But the evidence is accumulating across a number of other sites, as you can see here. As it relates to cancer survivorship or quality of life, part of that roundtable also looked at actual dosing of physical activity or exercise for cancer patients who are dealing with different types of symptoms. So there is, from both randomized control studies as well as observational studies, a sufficient amount of data to actually link aerobic or resistance exercise to a number of different types of symptom management, ranging from anxiety and depression to fatigue, overall global mental and physical health, improved physical function, and then specific factors like managing lymphedema. So this has all led to now an entire initiative called Moving Through Cancer, where this is just a snapshot of what an exercise prescription pad looks like. But clinicians are actually given these types of prescription pads under the umbrella of exercise as medicine to help actually guide cancer survivors and patients during active treatment in understanding what aerobic activity is, what strength training activity is, and dosing the amount of activity they should aim to get to be able to mitigate some of these symptoms. So we're making a lot of progress in this space of managing the experience and quality of life of cancer patients after their diagnosis and treatment. So in terms of the epidemiologic evidence, there's strong evidence for an association between many different types of cancer and physical activity, as well as epidemiologic and randomized controlled trial evidence that physical activity improves both survival as well as symptom management after diagnosis. But there's clearly a lot of work yet to be done in this space. And this really is focused on additional studies to characterize the optimal dose, how to bout physical activity, common questions like, if I only exercise on the weekends, but I'm getting the total amount, is that the same as spreading it out throughout the week? What do those patterns of activity need to look like? We oftentimes hear 10 minutes a day or 10-minute bouts. That's largely based on what we see for cardiovascular disease, but we don't know what that means for cancer patients. And what types of exercise may be better for both cancer prevention as well as improved outcomes. So to that end, one of the big initiatives at the American Cancer Society is expanding the shift from survey-based assessment to including other types of assessment. And this is where I think the intersect with the biomechanics space is really exciting. So I wanted to share in my last few slides just some of where our thoughts are and the study that we've launched. So of course, understanding not just your intentional exercise, but the fact that sedentary time is increasing and has been increasing dramatically in leisure time. You can see here that orange line going up is the amount of leisure time spent in front of a screen, and the blue line is active leisure time. So going in the exact opposite direction of what we think we need to be seeing in the population. When we think about the work environment, the two lines that are going up over time are light intensity activity and sedentary time, but with technology, dramatic decreases overall in moderate intensity activity in the workplace. And transportation, we're more and more dependent on cars, and with urban sprawl, more and more seeing cul-de-sac communities where you don't have anywhere to walk from point A to point B. So we've never been a big active transport country, but we've seen that decline in the US even further. So understanding and expanding beyond the focus of exercise in that 24-hour day to the role of really the 24-hour behaviors because as one goes down, another goes up. So really understanding how all of these factors play into cancer risk and prognosis is an important area of research. So we've built a study called the Cancer Prevention Study 3. This was built ending in 2013. It is just over 300,000 people who were cancer-free at the time that they enrolled in the study. They are surveyed through the more traditional epidemiologic surveys every 3 years. But we've also done a number of enhancements, including most recently launching an accelerometry-based sub-study where we're actually having participants wear, for an extended period of time, a research-grade accelerometer to capture those bouts and patterns of movement in about 20,000 individuals. You'll hear more about some of these types of enhancements in the last talk of the day. But these participants are all across the US, about 3/4 women, about 20% non-white participants, younger than past studies with an average age of study enrollment at 48, so we can really understand those middle adult years. And importantly, we've collected blood samples so that we can also look at genetic drivers as well as other markers that may be important to physical activity. And all of this survey-based data, the blood samples, along with then layering of physical activity built environment data, walkability indices, green space, traffic density, availability of sidewalks, and so on, give us really broad sweeping landscapes of the physical activity environment and individual behavior. But we've also built in newer things like a video-based 30-second sit-stand chair test, so we can actually over time remotely administer this type of generally clinic-based test through these types of large-scale epidemiologic studies. I mentioned the accelerometry sub-study, and we're now looking at the integration of commercial devices as well for the measurement of physical activity. So as you think about those future questions, definitely think about whether or not there are other opportunities to do direct measurement through populations like this. So just wanted to leave you with a snapshot of where the field broadly in population science is headed. And with that, I'll just share one of my favorite cartoons and happy to take a question as we're switching over to our next speaker.
Thank you, Alpa. So just a reminder, you can ask questions in the chat room during the talks, and I can have something ready to go right now while we're switching speakers. I just lost my note in my chat room. Someone just said something. So with a question from the room, in your opinion, how relevant are multiple barriers to physical activity, like the stage of diagnosis or chemo and radiation therapy?
So for most cancer patients, and we're talking probably 90%, exercise is likely safe and doable. I think one of the big messages that we're trying to focus on at the population level is do what you can at where and when you can. But we should always, of course, be talking to our oncology care teams about whether or not and how adjustments should be made. But for the vast majority of patients across stages and across cancer types and treatment types, physical activity is largely very safe.
Great. All right. Thank you, Alpa. All right, so we'll move on to our next speaker. So Ajit Chaudhari is a professor at Ohio State University, and he'll be talking about changes to balance and gait with chemotherapy.
All right, thanks, David. So thank you, Alpa, for that great overview about physical activity throughout the continuum. I'm going to focus in now on balance and gait in cancer survivors. And I want to acknowledge Scott Monfort. This is all his PhD work, as well as Miriam Lusberg, who is my medical oncology collaborator, as well as National Cancer Institute for some of the funding. So chemotherapy-induced neuropathy is a big and growing problem. We have nearly 5 million survivors of breast and colorectal cancers in particular. Now, all of the cancers or survivorship's getting better, and that's partially because of chemotherapy getting better. But several of the agents, such as taxanes, that's a class of chemo agents, often present patients with adverse side effects. And that can include things like peripheral neuropathy, which is sensed by patients as pain, tingling, or numbness in their hands and feet, as well as what's called chemo brain or chemo fog, where the patient says, I just don't feel like I'm thinking as clearly as I used to be able to. And my sort of entry into this area came from talking with Dr. Lusberg, and she said, I see my patients stumbling halfway through chemotherapy, but I don't know how to quantify it, and I don't really even know if it matters or not. And since we had that conversation, some more studies have been published showing that there's an increased risk of falling, in particular in this population, with 74% of cancer survivors over 60 reporting a fall. And as you know, most of us in the audience know, falls are a big problem, especially as people age. So where's our gap in knowledge here? So we have, lots of reports of chemotherapy leading to negative changes to the nervous system. And as biomechanists, we know that changes to the nervous system should affect your movement and stability, but we haven't really shown it in balance or gait. So I'm going to talk about 3 studies that we published fairly recently that are all looking at this issue. So the first one is how do balance and gait impairments develop with chemotherapy, and this was published in 2017. So we had patients who we tested at the beginning of every chemotherapy cycle. So that was 4 cycles, approximately 2 weeks apart. And then we had a final testing time point 1 to 3 months after chemotherapy was done. And we measured quiet standing balance. We also measured a 10-meter walk, but I'm just going to focus on the quiet stance. So here on this graph, on the x-axis, you can see the time points. And then on the y-axis, just as an example, I'm showing the 95% ellipse area, which of course is a measure of your postural sway. The black triangles are showing eyes open, red squares are eyes closed. And I'm just going to focus on that eyes closed. And what we see is this cumulative increase in postural sway through the course of chemotherapy, and it's not getting better even 1 to 3 months after completing chemo. Now, how big of a change is that? These folks are about 47 and a half years old on average. So compare that 80% increase to a 28% increase that's known to result from about 40 years of aging. So this difference is much bigger than what we see with 40 years of aging. Okay, next study was looking at how postural control strategies, or sort of your sensory organization and integration changes following neurotoxic chemotherapy. And this was published in 2019. So this was cross-sectional. It was after chemotherapy was done. We had a control group who had just had surgery but didn't need chemo. Then we had a group that had chemo but wasn't showing any symptoms of neuropathy, and then a group that had symptoms of neuropathy. And we did what's called a sensory organization test, where we're having them do standing balance while we limit different senses. And then we calculated what's called a sensory interference ratio, which is basically showing us how dependent you are on that sensory modality. So when we take it away, how much worse do you get? And we did that with vision. We did that with somatosensory or proprioception by putting them on foam, and then vestibular by making them tilt their head back. So here on the x-axis, you can see these bars for taking away vision, taking away somatosensory, taking away vestibular. And then on the y-axis, we have increased sensory interference ratio. So you have a greater ratio. That means that you had a greater dependence on that sense. And so if we look at the first set, we can see that's when we take away vision, we see that the peripheral neuropathy folks, they are more dependent on vision because theirs gets much worse when we take away vision. On the other hand, when we look at the center one, the somatosensory, the control group is more dependent on that somatosensory sensation. Or maybe we could say that the chemotherapy and CIPN groups have down-weighted how much they depend on somatosensory, perhaps because they know that it's not as high quality information. Okay, so the next study is actually looking at how these central and peripheral nervous system impairments associated with chemotherapy affect gait. This one was also published in 2019. So this is the same participants as we looked at balance. But this time we did single and dual task treadmill gait, where the dual task was having them count down by sevens. We measured executive function with the Groton-Maze learning test. So that's a test of executive function, or sort of your ability to focus your conscious attention, and then proprioception with an active ankle repositioning error test. And our two outcomes that we were looking at here had to do with stability of your gait. So orbital stability, we measure with the flow K multiplier. So that's looking at if on one step you kind of go away from equilibrium, how many gait cycles basically does it take you to sort of get back to equilibrium? And then the other one is called local stability, and that's the short time scale Lyapunov exponent, which is really looking at over very short time scales. If you initially have a little difference, do you tend to go back to equilibrium quickly, or do you even diverge? So I'm just going to focus on one result here. So the x-axis is worse executive function, meaning more errors in this maze learning task. And then on the y-axis is greater dual task impairment. So meaning when we switch from single task to dual task, how much worse does your orbital stability get? So first I'll show you the results for everybody. The blue circles are the control group, pretty flat line here. The red squares are the chemo group without peripheral neuropathy, again, fairly flat. And then the third group is the group with peripheral neuropathy symptoms. And if I just sort of focus in on that, what we see is this really strong relationship. So the worse their executive function, we think that means that they're focusing more of their executive, more of their conscious attention on maintaining really stable gait, which they can do fine when we have a single task. But when we add the dual task, where they're counting, they can't compensate with executive focus. And so then their gait becomes much less stable. So in conclusion, balance and gait are affected by chemotherapy. So we see longitudinal changes in balance and gait with chemo. Those changes are cumulative, they're clinically meaningful, and they don't resolve spontaneously when the chemo ends. And then we also see changes in how the brain is integrating sensory information with people who have neuropathy. So during balance, we see reduced dependence on proprioception, increased dependence on vision. And then during gait, we see increased dependence on executive function or conscious attention to maintain that stability during gait. And so it's really important to remember that all of these changes may increase the risk of falls, they may increase the risk of reduced independence, and they may increase the risk of reduced physical activity. So, coming back to that question that we had after Alpa's talk, these symptoms may affect what activities somebody can do, feels comfortable doing, and will do in their lives. So I think this is really important to take into account. And so with that, I guess I'll stop sharing. And I'm going to turn it over to David Lips from University of Michigan. He's going to talk about the effects of radiation therapy on upper extremity movement.
David, you're muted.
And I am muted. Cool. All right. So that was a really great talk on the effects of chemotherapy and biomechanics. I'm going to talk a little bit about the effects of radiation therapy on muscle mechanics. And to acknowledge this work would not be possible without having some great clinical partners and some great radiation oncologists work with me on it. And for any of those interested in getting in the field later on, find yourself a really good clinical partner. All right. So radiation therapy is commonly used in the management for breast cancer. It's very important for managing breast cancer recurrence. This is particularly important for women who undergo a lumpectomy. So lumpectomy is a surgery where they basically take the tumor and a little bit of tissue around the tumor, and then to ensure that they eliminate all the cancer cells, they will then go through radiation procedures for approximately a month every day in order to target and eliminate the remaining cancer cells and reduce the risk of recurrence. So a typical treatment for a woman who has a tumor that does not spread into the lymph nodes is they would have radiation delivered by 2 beams to the breast and chest wall, which is kind of approximated here by this yellow field. For women who have more advanced disease, this means that the disease has spread into the lymph nodes and there's risk of it spreading and becoming a metastatic cancer. They also need to treat the lymph nodes with an additional field, kind of illustrated here in red, going after these supraclavicular nodes. There's certainly functional morbidity associated with radiation therapy. It has been implicated with an increase in pain, reduced mobility at the shoulder, increase in fibrosis of the skin and the muscle, and an increase in the risk of lymphedema or swelling of the upper arm. In terms of the anatomical implications for doing breast irradiation, if you look at kind of the anatomy, you see the breast tissue here, this adipose tissue, and you can see directly underneath that, that's where the pectoralis major muscle sits. So you can imagine that if you are delivering any sort of radiation to the breast, you could potentially get some incidental radiation into the musculature. This becomes more prevalent when you start treating those lymphatic nodes. And you can see these lymph nodes here in purple and blue, and I'll illustrate them a little bit more in this next slide here, where you can clearly see those where these lymph nodes lie. They're very much intertwined with the shoulder musculature. So you're talking about the pectoralis major, the pectoralis minor, and latissimus dorsi, and some of those also other muscles around the shoulder girdle really sit around those lymph nodes. As you begin to treat those lymph nodes, it's potentially increasing the risk of injuring the muscles around those nodes. So I'm going to talk about 3 studies that our lab has done over the last 5 or so years, looking at a couple of different knowledge gaps. The first being which muscle or muscles are most likely to be impacted by radiation treatment for breast cancer. So one of the really nice things in terms of a researcher working with radiation patients is that all of these patients prior to radiation undergo basically a half body scan, basically from the neck through the chest, of CT scan that they use for planning their radiation prescription. And from those same CT scans, you can potentially look at the individual muscle volumes within those scans. So what we did initially is we took radiation treatments that we simulated for the 5 most common field designs for breast cancer. We used scans from 11 different women to look at a variety of anatomies. I only show 2 here above. And basically what you see here is these kind of isodose circles up here in the upper quadrants of both of these. What you're seeing is where you're getting 40, 45, and 50 gray, which is the maximum dose in purple here of treatment in these 2 different field designs. We looked at 5, only 2 are pictured here. On these same scans, we went ahead, and this is just one slice, but we used the entire volume of these muscles to identify where the individual shoulder muscles lie, potentially within these treatment volumes. So this is just a treatment volume for just the breast. This is breast with high tangents, trying to get some of those higher up nodes. You can clearly see that the pectoralis major and minor are in the volume here, but as you increase the fields to cover those lymph nodes, you begin to see getting increasing doses going to other muscles here, like the latissimus dorsi and the teres major. So we did this for 11 shoulder muscles, and then we calculated the radiation dose for each muscle volume in treatment. And what we basically found is that as you increase radiation treatment volumes to target these lymph nodes, you're putting 4 muscles at significant risk for increased radiation dose, approaching near the maximum dose delivered to the breast tissue themselves. It includes the pectoralis major, the pectoralis minor, the teres major, and latissimus dorsi. However, this was just a sensitivity analysis in 11 patients. These patients didn't undergo 5 different treatments individually for breast cancer, so we have no real functional outcomes for these patients to tie to this data. Which led us to our second study, which is to look at how does a radiation dose delivered to muscle relate to muscle stiffness post-RT. To do this, we looked at ultrasound shear wave elastography. This is an approach that's been taught in the biomechanics community before, but it's a nice way of kind of quantifying muscle stiffness. So what we basically do is we propagate waves within the tissue with an ultrasound transducer, and basically the speed of these shear waves is proportional to the shear elastic modulus and ultimately the stiffness of that tissue. So basically, as these color maps get brighter, it's indicative of a stiffer tissue. So to do this, we looked at the effect of radiation therapy on muscle stiffness in 3 cohorts. We took a first cohort, which was basically a group that got radiation to both the breast and the regional nodes. So this is the group that got the most amount of radiation. A second group that just got radiation to the breast alone, and then a third cohort of women with no cancer diagnosis, perfectly healthy shoulder, no orthopedic injuries prior to the shoulder. All of these samples, by the way, were taken 18 months post-radiation therapy. So to kind of present our results, I'll talk about the group results, but I'm going to give the color maps because I think it really tells the story. So when you take women who are completely healthy and you look at the shear wave both in the clavicular fiber region or in the sternocostal fiber region, so the top 2 of the clavicular fiber region, bottom 2 of the sternocostal, you can look at them either relaxed or as they're contracting like 10% of their maximum voluntary contraction, I believe forward in flexion in this case. So this is what the maps look like for a healthy control. If you take a woman who has radiation delivered just to the breast, no inclusion of the regional nodes, while some radiation may get into the pec, it does not seem to result in any sort of real visual difference or quantifiable difference between this group of women breast radiation therapy to these healthy controls. Where you really notice the differences though is when you start including these regional nodes. So you can clearly see it does not matter if you look at the clavicular fiber region or the sternocostal fiber region. It doesn't matter if you look at them relaxed or while contracting force. There is a markedly increase in stiffness of the pectoralis major when you're treating these women to the regional nodes and the breast. We also went ahead and we got those treatment plans for those same patients in group 1 and group 2. So the women who had a lot of radiation and some who had less. And we basically we're interested in seeing if the radiation dose delivered to the pectoralis major was related to our corresponding shear wave velocity measured with our ultrasound techniques. And we did find a positive correlation here in this retrospective sample. So again, this is a retrospective sample of only 18 women, but it does give us some evidence to believe that this is something worth pursuing a little bit further, that something is going on with these women in terms of the muscle getting stiffer as the dose increases. So we were then interested in looking at how muscle stiffness prospectively changes across the course of cancer treatment and recovery. To do this, we took 7 women undergoing a standard radiation treatment plan. So this was radiation just to the breast, not to the regional nodes. And we looked at how the muscle changes basically at baseline prior to any of their cancer surgeries, and when we look at them 6 months after radiation therapy. So these are women who are treated unilaterally. So one side was treated with breast cancer, the other side didn't get treated for cancer and had no radiation delivered to it. So on the untreated arm, if you look at the shear velocity of the pectoralis major, we only see a 2% increase in shear velocity, so nothing significant on their untreated side. 6 months after radiation, we begin to see about a 15% increase on average in the shear velocity we detect in the pectoralis major on the treated side. And it's also important to note that radiation is generally viewed as a late toxicity of cancer treatment, that typically people may not present any sort of morbidity until 1, 2, 3 years after treatment. The fact that we're beginning to see some of these signs at 6 months, we think is potentially indicative that this technology could be useful and be able to screen people and catch them earlier on before they're severely impacted by their treatments. So kind of my take-home messages for today, radiation therapy is most likely to impact the pectoralis major, minor, latissimus dorsi, and teres major based on their anatomical placements within the treatment fields. We've noticed increase in stiffness of the pectoralis major muscle after radiation therapy is significantly correlated with the radiation dose delivered to that muscle during treatment. And the pectoralis major exhibits prospective changes in muscle stiffness across the course of treatment and recovery up to 6 months post rehabilitation. So with that, I want to thank all the people who have worked on a variety of breast cancer studies in my lab over the course of the last 5 years. This study was funded by Susan Komen But we've also had some additional funding in the lab that's also supported some of this work, the American Cancer Society and the NICHD. So with that, where are we on time here? I'll stop my slides. We could take a question for Ajit while we turn over to Jackie. So Ajit, we did have a question for you previously. Have you performed any joint level assessments of gait? I lost my question. During and after chemotherapy?
So we do have that data. We haven't seen anything that's sort of systematically apparent, but I think that is mostly due to the fact, or it could be mostly due to the fact that it's fairly small sample and there's just a lot of variability between people. But I guess the short answer is we haven't seen it, but it may be there. I think more work, having larger sample sizes is really going to be helpful to answer that question.
All right, so we are now going to turn it over to Jackie Mitchell-Kevich, who's going to be talking about investigating the influence of temporality on function in breast cancer survivors.
All right, thanks for the introduction and thanks for inviting me to be a part of the symposium. Is it going to advance? There we go. So I'm actually north of the border. I'm up in Waterloo. So my stats here are on Canadian, but if you imagine like multiplying them by 10, that's about where you would see American stats. So it's the most common cancer among Canadian women. And so for that purposes, I'm just looking at women, but I just want to acknowledge that it does affect males as well. And 1 in 9 Canadian women will develop breast cancer by the age of 90. So it occurs primarily between the ages of 50 and 69, which means that 72% of the diagnoses are occurring within workforce age population. And with our survival rate at 88%, 22,000 new survivors join the population each year. So that's about 220,000 in the States. So we've already talked about what treatment these individuals receive. So we know that radiation effects can have long-lasting effects. Chemotherapy affects our entire body. And as well, they have surgical interventions. In total, we see decreases of strength in up to 40% of survivors, range of motion decreases in up to 67% of survivors. And then we have quality of life, which is largely associated with these decreases in function. Breast cancer survivors also use less range of motion on their affected side in daily tasks. And we see increased activation for the same task. So an individual completing the same maximal task or activity of daily living will use more muscular activation to complete the same thing. There's not a great understanding of when these occur. And we see studies looking at survivors or individuals during treatment all the way up to 19 years past treatment. So it's been really difficult to figure out when these are actually affecting and how severe they can be. So this study and series of studies aimed to determine the influence of time from treatment on maximal strength and range of motion and the associated muscular activation, as well as kinematics during activities of daily living. So just to give you a really quick overview of the studies I'm talking about, we had 28 female breast cancer survivors, and they were divided on 2 different times from treatment. So within 1 year from the end of treatment, whatever was their last intervention, and between 1 and 2 years since treatment. So we really wanted to target people early on in their survivorship. So we used Neuraxon to look at force and muscular activation, and as well as kinematics. So for the purposes of today, just based on time, I'm actually not going to present any of the muscular activation. I'm going to touch on it briefly on the slides, but I don't have any of that information, but that has all been processed and is ready for publication. So if you're interested, go ahead and ask. So we looked at abduction, adduction, external rotation, internal rotation, flexion, and extension. And we had a force cuff above the elbow so that we could really focus on shoulder strength and not where we typically use a dynamometer, and that could have the full arm. And we also looked at abduction, external rotation, internal rotation, flexion, extension, and scapular abduction range of motion. After these maximal tasks, we also looked at a series of activities of daily living because we know that those can be affected as well. And we looked at a lift of 5 kilograms from the floor to waist height, a simulated bra fasten, putting on a necklace, pouring from a pitcher, reaching forward with a 1 kilogram weight, and reaching to a shelf with a 1 kilogram weight, and that shelf was at a chromium height. So for our strength trials, we obviously looked at maximum force for each of the isometric strength trials. And the range of motion ADL is where things can be a little confusing, and I'll remind you when we get to the slide. So for range of motion tests, we looked at maximal angle for range of motion, so the max they could reach. And in the ADL test, we looked at the range, so max minus min. So to get into it here, we can see this is the range of motion, the maximal. So we're looking at max angle here. For abduction, scapular abduction, extension, and flexion, we're looking at elevation angle. And for external rotation and internal rotation, we're looking at axial rotation. So here there wasn't too much difference between our two groups. So T1 is the group that's within 1 year since the end of treatment, and T1-2 is between 1 and 2 years. So we see approximately 15.5 degrees less scapular abduction in the group further from treatment, and then about 11.5 degrees in flexion. And in force production, or maximal strength, is where we see a lot more differences. So again, the same groups here, and we're looking at max force. We saw 30.5 newtons less force production in extension in our group further from treatment. External rotation was about 28 newtons less. Flexion is 34.5 newtons less. And then the biggest difference was in internal rotation, where it was almost 44 newtons less in our group further from treatment. And then this is our ADL test and the kinematics. So again, this is our range of motion, so max minus min, not maximal angle. So if you're not familiar with the shoulder, plane of elevation is what you can imagine like a horizontal abduction. So like moving across this plane, if you can see my video, elevation angle is up and down, and then axial rotation is rotation. So this is all thoracohumeral joints here. So plane of elevation across multiple tasks. So the bag lift and our shelf lift and our reach were significantly different. And on average, our group further from treatment used 12.3 degrees less plane of elevation. Elevation angle is the one that we hear about the most restriction. And again, that's happening, more restrictions happening further from treatment. On average, about 30 degrees less over our bag task, necklace task, pitcher, shelf, and our shelf. And finally, if we look at axial rotation, we see about 22 degrees less in our bra task, necklace task, pitcher task, reach, and shelf. So all except for our bag task. And I also promised I would give you a little snippet of muscular activation. So what we see in these is a similar trend where there's significantly different. Pectoralis major, sternal, and clavicular had the greatest differences. And we saw increased activation over these tasks for the group that is further from treatment. So again, as a reminder, they're using less motion, they're more restricted, but they're using more muscular activation. So just to kind of bring that all together, we see these lingering effects from treatment. So David was speaking about how radiation they see these effects 6 months later. So that's being mimicked here, where we see more a reduction in movement, increased activation, decreased strength, all of that. And we know that breast cancer survivors, although they're able to complete the ADLs, they are reporting pain, and that we still see these differences. Importantly, we also see this decreased range of motion in ADLs. That's a similar strategy to people with rotator cuff disorders. And so it's possible that these individuals are having more comorbidities, or that we could see increased injuries in these individuals. And all of this is really important to consider because it has return to work implications. So whether people will be able to complete what they previously did, or whether or not, again, this is going to make them more prone to injuries. So the delayed onset of strength and movement changes occurs as we go further from treatment. And we see possible compensations occurring in these individuals, which may lead to injuries. This has implications for quality of life and return to work for these individuals. And importantly, knowing that these happen further from treatment, we need to know when we need to have these interventions occurring for breast cancer survivors. I just want to thank our funding agencies as well as the Diesel Lab. And I'm happy to take any questions later. I don't actually have, I think I took about my whole time, so we can move forward.
Hey, Jackie, there's a question in the room for you, but we'll just ask you at the end. I think we're a few minutes behind, so I'll let Joe get started here. So Jonah Sarah from Emory will be talking about resistance training to improve fatigue and physical functioning in postmenopausal breast cancer survivors. Take it away, Joe.
All right, thank you. And thanks everybody for joining. Really glad to be a part of this discussion. I am going to warn you, I have quite a storm rolling through Atlanta, so that is not my stomach rumbling if you hear something in the background. So I want to thank a collaborator and colleague of mine, Monica Sarah. Much of this work has been based on her work. Oops, sorry. No disclosures. So I'm going to just get into a brief background. Some of this you've already heard, and then discuss an ongoing study that we have, hoping to pick it back up as things hopefully lessen with COVID on resistance training and postmenopausal breast cancer survivors. And then really want to briefly highlight some of our next steps and future research directions. So as you've heard, there is significant cancer consequences among survivors, particularly in this case, we're going to talk about breast cancer survivors. So we know that specific to cancer, we had 1.8 million new cancer cases in 2020, and a large portion, as you heard, of those are breast cancer. So the effects of this, whether you're talking about psychological or treatment side effects, often result in decreased physical activity. And it's estimated, in fact, that women specifically decrease their activity levels by 2 hours per week after the diagnosis of breast cancer. So that the chances of them meeting those guidelines that we've highlighted is pretty low. And then it often declines, the rate of physical activity declines during treatment, particularly those undergoing chemo and radiation, and most often does not return to pre-treatment levels. So collectively, what you get is a sort of a vicious cycle of increased inflammation related to the decreased activity, and some long-term consequences, including functional limitations, deconditioning, fatigue, and depression, as well as some metabolic abnormalities. Now, for today, due to time, I'm going to primarily just focus on our work looking at functional changes and fatigue following an intervention. So specific to functional limitations, what we see is that compared to age-matched controls, non-cancer controls, we have lower peak cardiovascular fitness, 40% lower strength. Recent and long-term cancer survivors are more likely to report difficulties with ADLs, and this also correlates with higher levels of fatigue. And then 50% report physical limitations, and so this includes walking, crouching, lifting, standing, which can restrict chores, preparing meals, using a fork. So just these day-to-day activities that they live in, they're very highly related to quality of life. And what's interesting is now the late 1980s probably seems like a long time ago, but in terms of research, we're kind of behind. It was recommended to rest and avoid exercise for cancer survivors in terms of all the way as recent as the late 80s. So we really are behind when you think about some of the advances that have been made in training and exercise phys. So importantly, however, there have been some studies. There was a recent meta-analysis, and there were 66 studies that were considered to be of high quality, and these were comparing outcomes post-treatment versus during treatment with exercise. And you can see that there was some positive gains with psychological stress, anxiety, pain, quality of life, fatigue was highly relevant there. Muscle mass and function, so lean mass, aerobic fitness, strength. Now, what's important to note is that of these studies, 88% were noted as being aerobic in nature. And there's certainly nothing wrong with aerobic exercise. These were treatments like walking or brisk walk, light jogging. But for a variety of reasons, there's important implications for looking at other types of exercise interventions. And one which we really have done a considerable amount of work in, both in cancer and non-related to cancer, is resistance and strength training. And there's quite a variety of reasons why we like looking at resistance training. One in particular is that some people enjoy that more versus cardiovascular fitness, and there's cardiovascular training. And when you can compare something that's quote unquote aerobic in nature, we can also get to a target heart rate with certain types of resistance training. So for example, interval-based training, which we've looked at as well. So why resistance training? Well, most adults age 50 to 70 experience a 30% loss in muscle mass. And so there is this deterioration in muscle quality and quantity that leads to slower movement, decline in strength and power, and increased risk of falls. And we have already heard the significant amount of falls that cancer patients experience. And importantly, resistance training is one of the most effective strategies for improving muscle mass and function and managing sarcopenia, which is a sort of an age-related decline in muscle function. Now, anytime you're talking about implementing an exercise intervention, you cannot ignore barriers, and there are significant barriers, but oftentimes we find that they are addressable. And so I do like to highlight that some of the barriers that we hear or run into and try to work on is that there are limited age appropriate programs, which is exciting, is that really over the last 10, 20 years, that has changed dramatically. And that's been a really good source of increased function in a variety of populations. Fear of a gym setting is something we hear quite often. No access or poor access to a gym, particularly in the current situation with COVID now. Pain can often impact how somebody wants to exercise. And then lack of social support. So we find that it's extremely beneficial to have social support in place, whether that's a caregiver or a group-based exercise intervention, to kind of push the adherence. So what we were interested in doing is looking at the effects of a 4-month resistance training program in postmenopausal breast cancer survivors. And what we were looking at was muscle function, so both muscle strength and mobility function. And then we had subjective outcomes, including fatigue and quality of life. Now, we did have some muscle quality outcomes and also looking at measures of inflammation, as well as general adherence. And for purposes of time, I'm not going to present on those. So this is what our sample looked like. Again, this is an ongoing, fairly small study, but you can see it's a fairly diverse in terms of about roughly half Caucasian, half African-American. You can see the months since diagnosis. And then if you look at the age and BMI, that really does put them in kind of a prime target for increased sarcopenia and loss of muscle mass and function. So a really good population to target with strength training. So what we found was when we looked at our muscle function outcomes, you can see the 6-minute walk had a significant increase. And actually this cohort started out as relatively fit. The norm is 540 meters. And you can see we're approaching that certainly at post, but this was a relatively fit group to start with. But they did significantly improve. And then when you look at chair stands, so lower leg muscle strength, you could see the amount of time it took to do 5 chair stands significantly reduced. Now, the time for each of these, so it was a 21-meter increase and a 1.5-second decrease. Clinical significance is a 2.3-second decrease and a 50-meter increase. But there is still relevance here, but not to the level of statistical significance. So, longer intervention may be warranted. And we look at quality of life. So there's the physical component score of the SF-36, and this is composed of 4 scales, which really do a nice job of assessing physical function, role limitations caused by physical problems, pain, and then general health. And you can see a 10% in significant improvement in that, and then a significant improvement in vitality. And we also talked about fatigue. And so this fatigue index was originally developed to measure fatigue specifically in cancer patients. It's been successfully used in a variety of areas over the last 20 years. And the results will tell you the degree which fatigue is impacting several key areas of one's life. So senses, thinking, behavior, emotions, and then overall. And what we showed was that from pre to post intervention, our groups as a whole went from moderate fatigue to mild fatigue, which was, again, significantly different from pre to post. So that's some exciting, heading in the right direction. There's definitely some work to be done, and certainly some implications for strength training in this population. But there are certainly challenges and more work that needs to be done. So the effectiveness and generalizability to overall population of survivors, for example, long-term effects and optimal training prescription. But again, this is just another modality, right? So there's more work looking at aerobic training in nature, and the idea is that we can potentially look at other modalities of exercise mechanisms. So there is certainly a need to understand mechanisms of not only decrease in function in muscle, for example, with treatments, but also the benefits that strength training and other exercise interventions may be responsible for, but really understanding those mechanisms and how they can impact therapy. And then there's also always adjunctive therapies, things like nutrition, looking at other outcomes that impact these outcomes, for example, sleep, which is a big one. So one thing I did briefly want to touch on as my time finishes up is that we do have a challenge in that how we can have healthcare professionals successfully prescribe exercise, and the idea of using a script and prescribing exercise is excellent, and I know that's made a lot of headway. So that's exciting. But there is other opportunities, and one thing that we've been looking at is the use of technology. So with remote exercise, and you can imagine that this has also picked up quite a bit of steam over the last 18 months. But this is work that has been done with a colleague of mine that's a cardiologist using cardiac rehab. And we're in the process of translating this into other patient populations, including breast cancer survivors. So it utilizes wearable sensors, connected devices, so that we can monitor these patients in their quote unquote real world environment and make suggestions and prescribe exercise by way of the information that we're getting back. A lot of work to be done in this area, but certainly with the advances of wearables and technology in general, it's an exciting way that we can impact more breast cancer survivors. And so this is just an example. You can see that the individual could be alerted. They can log their activity. There's videos in there, and then they can real-time chat with a study coordinator, for example, or even a clinician, as in the case of how we have it with our cardiology partners. So with that, I believe that's my last slide. So I do want to thank Dr. Lips for this invitation, and my other presenters. Been really great thus far. I mentioned Dr. Monica Serra, who's done a lot of this work, and the amazing participants that have volunteered for our studies, my colleagues, and then funding agencies, specifically the Winship Cancer Institute. So thank you very much, and we can move on, or if there's time for questions. I'm not sure where we're at on the time.
So I think we're going to move on to the last presentation, and we'll just do questions for the entire panel afterwards. So we will. Joe's talk feeds in really nicely, I think, to what Erica Rees-Punia is going to talk about today on digital interventions for physical activity promotion in cancer survivors. So if you want to go ahead and share your screen.
Yes. All right. So, all right. I trust you guys can see all that.
Yes, you're good to go.
Perfect. Awesome. So yeah, I'm Erica Rees-Punia. I'm a principal scientist at the American Cancer Society. I am an exercise physiologist by training, but now I guess I consider myself more of a behavioral scientist / epidemiologist. but still an exercise scientist at the same time. So today I'm going to be talking about digital interventions for physical activity promotion in cancer survivors, in particular, one that we're planning currently at the American Cancer Society, although I will give a little bit of background on some other digital interventions that exist. And of course, you just saw some snippets from Joe's as well. So, but starting off, in 2019, there were over 16 million cancer survivors in the United States. And, you know, as you can imagine, with better treatment, early detection, this number is definitely going to be growing over the years. And as we've touched on throughout all the presentations, these survivors experience a whole wide range of side effects from both the disease itself and the treatment. And a lot of studies suggest that physical activity, in addition to being safe for cancer survivors, is an effective non-pharmacologic treatment for many of these side effects. Yet we know that really only about 15% of cancer survivors are meeting both the strength and aerobic guidelines. And this is low. It's low, period, but it's also pretty low when you think about comparing them to adults of the same age that have no history of cancer, where about 21% are meeting both that strength and aerobic guidelines. So, of course, there already exists tons of physical activity interventions for cancer survivors, and they range in many different ways. Most of the physical activity interventions that exist out there in the literature are in person, and this is beneficial in so many ways. This is an intervention that I worked on when I was back at University of Georgia. But it's also a little bit limiting in terms of resources and sustainability. And of course, if you think about times like now during a global pandemic, or perhaps people who live in rural areas or don't have access to a car, it's not the most it's not the best option for those people or during those times. Most of the other physical activity interventions also focus on really one type of cancer, overwhelmingly breast cancer, which of course is a very common one. So it's a great one to focus on. But there are many other types of cancers as well, and several that are also associated with physical inactivity beyond breast. We mentioned them earlier, but colon, kidney, bladder, and endometrium are all cancers that have a relatively high 5-year survival and are associated with physical inactivity and therefore pretty good targets for intervention. Additionally, a lot of physical activity interventions tend to focus on moderate to vigorous physical activity, which again, undoubtedly important, but it really does account for a pretty small proportion of our full waking day. And we know also that our activities of daily living, our light physical activity, and sedentary time are pretty important for a lot of different outcomes that cancer survivors experience. And importantly, a lot of studies have shown that an increase in the moderate to vigorous physical activity does not always mean a decrease in sedentary time. So unfortunately, a lot of times when people increase their MVPA, what they're really just doing is decreasing their LPA and still staying pretty consistent with that sedentary time. And then the last thing I'll touch on is, with very few exceptions, for example, some of those listed here, a lot of physical activity interventions have not succeeded in reaching the masses. They really haven't gone far beyond a publication in a journal. They really are not reaching that 16 million people across the United States in terms of getting the survivors to be more active, which of course is no easy feat. I don't say that with a grain of salt by any means, but just throwing that out there as someone who works at the American Cancer Society and has is able to leverage the reputation that we have with cancer survivors. This is something I have in the back of my mind. So to address some of these issues, we have leveraged the Cancer Prevention Study 3 that was discussed in the first talk to develop the Health and Energy Through Active Living Every Day After Cancer Intervention, HEALED intervention for short, which is going to be tested in a 1-year RCT for survivors of physical inactivity related cancers. And these will be people all across the United States. So our goals, at least in the short term, are to increase accelerometer measured MVPA, LPA, and sedentary time, as well as strength training within our healed participants. And then again, if we are successful, the long-term hope is that we can disseminate this program to a wider range of cancer survivors through ACS's channels, again, with ACS being a trusted source for cancer survivors. So we did pilot the idea of the healed intervention in a 12-week RCT. And you'll recognize some names on this paper as people you got to hear from earlier. And really what we were looking for in that intervention was, do people like this website? Do people find it acceptable? Is it easy to use? How do people perceive it, in particular our cancer survivors? And what we found really is that people found that it was easy to use, they liked it. And we did see some small changes in strength training, though we weren't powered to see big changes in moderate to vigorous physical activity or sedentary time. But a lot of what we learned about the website in particular is helpful now that we are planning the full scale 1-year intervention that we will officially launch in 2022. So we are in the planning stages. So unfortunately, I don't have any results to show you, but I do plan to talk a bit about our plan, and hopefully, if you guys have any cool comments, we could still integrate them at this point. So we are going to invite all CPS3 participants who are survivors of stage 1 to 3 breast, colon, endometrium, kidney, bladder, or multiple myeloma survivors. They need to have an email address, of course, this being a digital intervention. Our website's in English at this point, with hopeful future goals of having a Spanish version. We don't want them to have been a part of the pilot. They need to be able to walk unassisted. At that point, they'll take a screening, a little screener online. Since this is a completely unsupervised physical activity intervention, it's entirely online, very hands-off on the side of the researcher, again, with our ultimate goal being to disseminate more broadly across the US. So we do need to make sure that they don't have any major health conditions wherein a unsupervised intervention might be not ideal. So our participants will complete baseline testing, which again will include 7 days of waist-worn, waking time only accelerometers. We use the GT3X Plus by Actograph, and that will allow us to estimate time in MVPA, LPA, and sedentary time. And then we've also got an online survey with some patient-reported outcomes, including energy fatigue, anxiety, depression, sleep quality, quantity, some cognitive function, and again, that video-guided 30-second sit-stand test. We do use the 30-second sit-stand test over the time to 5 stands, just because it was easier to create a video in helping people to get through that test. We just have a little timer in the corner that gets them through 30 seconds. And there's an exercise professional, aka me, walking them through the test while some participants take the test alongside them. And it's much more simple to administer, again, in a hands-off, completely remote way versus a time to 5. So after they complete the baseline testing, participants are going to be randomized to either the healed intervention or our control group. Our control group is it's another website, which is really just based on balance and flexibility. So we don't have any components of moderate to vigorous aerobic, really any type of exercise at all, but not even an MVPA. And we also don't have a lot of personalization or interactiveness in that website. It's really just based on flexibility and balance, mostly education only, delivered through video. So we will repeat our tests, both the accelerometer and the online survey, at 3 months, 6 months, and 1 year post-intervention. And again, the website is pretty interactive, and it is pretty, we are planning to update the content monthly so that hopefully people will be very engaged and wanting to come back. So again, the healed website is going to be very personalized and interactive. It'll actually start off with a little quiz to help personalize the experience, both in terms of what they see, and then it matches their level of fitness and their current exercise plan, which for most people will probably not really exist, and also around their access to different things that they have, as well as just their name, their preference for how they get notifications. Do they want a text or an email or a phone call? And then again, that control piece is very straightforward. It's education only through videos and infographics, really just based on balance flexibility. The HEALED website itself will have lots of different tools for increasing social support amongst the different participants. It'll be things like leaderboards, discussion boards. Every participant will have a little profile, sort of Facebook-esque in that way, so that they can get to know people, become friends, hopefully feel competitive, hopefully, just really get that social support for physical activity that we know is so important. We also have a lot of tools for increasing self-efficacy or their confidence in their ability to be active. So we do this through what we call an online gym, which is largely different videos, again, geared towards cancer survivors at various fitness levels, focusing again mostly on MVPA and strength training. We have a lot of goal-setting tools, including vision boards and diaries. Self-monitoring, we do integrate our website with a Fitbit. So participants will be syncing their Fitbits through there. We have different things like progress bars and challenges. And then there's a lot of tools for overcoming barriers. So different tools for helping with time management, and as well as some videos and information on how to be safe, with this particular focus on cancer, of course. So our future plans are to launch this, make it happen in 400 survivors. So again, these are all CPS3 cancer survivors. So there are people all across the US. It'd be men and women of our 6 different cancers that we are focusing on. So we're building the website right now. We're working on integrating it, making it the best website where we can build. And we are going to begin inviting participants in about April of 2022. So we've got a bit of time up front. It does take quite a bit of time to get this thing built and off the ground, but we've got time before we start. And then of course it will be a 1-year study, which is fairly hands-off with the exception of mailing our kits out to our participants, which really just includes the accelerometer. But long-term, again, if our study shows that our website is successful, meaning that we notice that people in the intervention group are getting more MVPA, more strength training, more LPA, and less sedentary time, the ultimate goal is to disseminate this website much more widely. And so one of the channels that we're hopefully considering is cancer.org, which we know is visited by lots of cancer survivors all over. And so we would hopefully be able to leverage that to get this out to the broader community. And with that, I will stop sharing.
All right, thank you so much, Erica. Give me 1 second so I can try and pin everyone. So we got a few minutes here to take questions. So if you have any questions, start putting them in the Q&A section. I'll start moderating them in a second. Why don't I see Alpa? There she is. All right, we got our panel up now. So the question I was going to lead off with, and I'll go to the questions from the room. For those not part of the biomechanics community, so those coming over for us from the American Cancer Society, I was curious if you can comment on if you could think of some low-hanging fruit that people in the biomechanics community should start investigating or contributing to in the field of cancer prevention, treatment, or survivorship. Especially, there's been a lot of work at the survivorship end, but not as much in the prevention treatment. So I was wondering if you could comment briefly on areas where you think biomechanists could potentially contribute to this field.
So I can jump in, and then Erica, anything you want to add? I think one piece of low-hanging fruit is similar to what we showed about implementing at the large population level things like sit, stand, chair test. What else is, what else are we learning in that biomechanics space that we need larger scale data to really be able to understand that population impact? And so testing within a study like CPS3, for instance, those types of that translational work at the larger scale, I think, is a prime opportunity.
And I'll quickly add, one of the major gaps that we have, and this was one of the gaps that was highlighted in one of the papers that Alpa shared by Campbell et al., is around bone health. We really don't know a whole lot about physical activity and bone health in cancer survivors in particular. And so I think there's a lot of potential work that might be of interest to you all. But as I, watched a lot of the presentations just now, I feel like I realized that there are probably, a lot of the work that we do, of course, is with cancer survivors who are done with treatment. But I think that there are probably a lot more gaps around very specific treatments and associated joint issues, bone issues, things like that, that might be good to know for a clinical cancer specialist, a clinical exercise cancer specialist in writing the exercise prescriptions. So I think a lot of the work that you guys are all doing is probably super, super helpful for people prescribing exercise at that level. So yeah.
All right. And then to turn it over to the biomechanists on the panel then, we had a question in the room. The management of physical morbidities associated with cancer therapies is largely reactive in nature, addressing something that presents after treatment. How do you or can you use your individual research agendas to improve the surveillance and early identification of these morbidities?
I'll say something real quick is I'm becoming more and more of a balance evangelist. And I think, one of the papers we're actually working on getting ready to submit is actually showing that changes in your balance precede self-reported changes in terms of your status. So, if you have some early warning system like balance that says you are on a path to develop neuropathy, then maybe something could be done earlier. Maybe exercise earlier might help mitigate the development of those problems, or maybe you change the treatment course a little bit as well. Right now, Dr. Lesberg, my oncologist, she sometimes changes chemotherapy treatment because people are complaining of symptoms. And she's worried about them falling. So she says, I'm going to dial back your chemotherapy. But if we knew that sooner, maybe we could do something different.
So to add on that, some of my doctoral work, the first study in that, we're trying to cluster individuals based on different facets of survivorship. So looking at like their maximal strength and range of motion, quality of life measures, and then also like what treatment they had, how old they were, how physically active, all of that kind of stuff. And kind of what's shaken out of that is one of the biggest things was internal rotation force. So if that's something that we know separates those individuals very quickly, and if that's something we could easily monitor clinically, I think maybe that's a good way of monitoring individuals, like one quick measure that we can look out for, and we can see if that starts to decrease, that maybe that individual is heading towards much more issues than somebody who's remaining stable. So if we can get that measure pre any treatments and then continue to monitor it, maybe that's one way that we can kind of flag people who might be headed down the road of deficits, and where we see some people who have absolutely no differences after, like they seem to be okay in the scale of they don't report any issues, they don't report any pain, and they seem to have pretty stable force compared to a quote unquote healthy individual. So that's kind of where like my individual research is kind of pinpointing those type of factors.
Maybe a question for those of you who work with exercise interventions. How do you think exercise recommendations should differ for a cancer survivor?
Yeah, that's a great question. And I think, whether we're talking about cancer survivors or just exercise in general, we still have to focus on the individual patient and individual assignment of a particular intervention. So you could imagine that, breast cancer, for example, someone may have upper extremity problems secondary to treatment. And so you need to tailor the intervention based on that, whether you're talking about strength training or something that's more aerobic in nature. Some treatments, bone was mentioned previously. So some treatments may impact osteoporosis, and that has to be a factor in how interventions are tailored. So it really has to focus on the individual, their level of fitness, and then their specific treatment.
Great. So it appears we're at time. My apologies, we ran out of time. We couldn't get to everyone's questions, but for those who have time after this, please come and join us in Spatial Chat S1, the Borrelia room, and we can continue these discussions and hopefully answer some of these remaining questions over there. So thank you to all of the panelists for your contributions to this today. And I look forward in future meetings to see more of the great work at the intersection of biomechanics and oncology. So have a great rest of your meeting, everyone.
Thanks, David.
Thank you.